Well, hello and welcome to the CSF Monthly Podcast for August. And this month I'm going to review two papers that have been uploaded to the CSF website, amongst a number of others. And the detailed slide set for these papers can be found on the website, and I really recommend these slides to you. They're crystal clear, they'll help you in your own education and CME, but also they're very useful for communicating key messages to other colleagues. Now, the first paper I want to highlight is a comparison of long-term safety and efficacy of upadacitinib to adalimumab and methotrexate in inadequate responders over 48 weeks. And first author here, Professor Roy Flesichmann from the University of Texas Southwestern in the US. Well, obviously we need more therapies to treat people with rheumatoid arthritis. It's a lifelong condition for which currently there is no cure. And as part of our normal treatment experience, patients frequently fail to achieve remission with current therapeutics. The SELECT COMPARE study was designed to explore switching to JAK inhibitors from TNF inhibitors without a washout period and vice versa over 48 weeks. Now, previously published data from the study have shown that upadacitinib was superior to placebo and adalimumab with background methotrexate therapy at 26 weeks. And this current paper focused on the longer-term data obtained from week 26 through week 48. So it's a follow-on in this respect. Patients were more than 18 years of age. They'd been receiving methotrexate for at least 3 months with active joint disease. They were randomized blindly to a 2:1 ratio of methotrexate plus upadacitinib 15 milligrams QD, adalimumab 40 milligrams every 2 weeks, or placebo. And patients from any group were rescued to either adalimumab or upadacitinib at week 14, 18, or 22 if they had a less than 20% improvement in tender or swollen joint count. At week 26 if their CDI was greater than 10. And all remaining placebo patients were switched to upadacitinib at week 26 as a default in the trial design. Now, the efficacy assessments for low disease activity and remission included a CDI, SDI, and a DAS28 ESR, all at the recommended cutoff points. And safety evaluation included SAEs, particular focus on herpes zoster and, of course, malignancies. Well, the key findings here, the data were consistent with week 26 findings through to week 48. Significantly more upadacitinib patients achieved LDA and remission versus adalimumab and placebo across all of the parameters measured. Inhibition of radiographic progression was significantly greater in both the upadacitinib and adalimumab groups compared to placebo, and radiographic inhibition was comparable when one compared upadacitinib and the adalimumab groups. Rescue was beneficial regardless of the drug to which one changed. However, improvement was greater in patients switching from adalimumab to upadacitinib versus upadacitinib to adalimumab. Remember, that's very much a follow-on study, secondary analysis. Safety was comparable at week 48 to week 26 in both continuing and rescue patient populations, and there were no new safety concerns. So what do we conclude here? Well, the authors suggest that the long-term safety and efficacy of upadacitinib and adalimumab at week 48 were consistent with the primary findings at week 26. I would tend to agree with that. Non-responders to upadacitinib and adalimumab groups benefited from rescue without a washout period, and that's really helpful to us in clinical practice. Washout periods are difficult for patients and a real nuisance for clinicians in terms of how we transition practicalities in life. So helpful new data, but confirming essentially what we knew already from that trial. Now, the second paper I want to talk about in particular this month compares pefcitinib, PEF, 100 milligrams and 150 milligrams to placebo in Japanese methotrexate inadequate responder patients. And the key author here, actually one of my fellow steering committee members, Professor Takeuchi from Keio University in Japan. So pefcitinib monotherapy has previously demonstrated efficacy with an acceptable safety profile in phase 2b trial in Japanese patients with moderate to severe rheumatoid arthritis. And this is a phase 3 study. It assessed efficacy and safety, 2 different doses of PEF in Japanese people with rheumatoid arthritis who were inadequate responders to methotrexate. Randomization was 1:1:1 to methotrexate plus pefcitinib 100 milligrams, 150 milligrams, or placebo. Primary endpoints, fairly typical, ACR20 at week 12 or early termination, and radiographic inhibition at week 28 or early termination. Safety measures were observed through 52 weeks, and these include treatment-emergent adverse events, herpes zoster, malignancy. And the inadequate responders in placebo group were blindly rescued at week 12 to pefsitinib, and all placebo patients were rescued to pefsitinib at week 28. So key results, well, the ACR 20, 50, 70 response rates were significantly greater for both those groups of pefsitinib compared to placebo at week 12. And in comparison to placebo, both groups had a significantly reduced mean change from baseline for radiographic progression, joint space narrowing, and erosion scores. The adverse events leading to permanent discontinuation were higher in the placebo group compared to both doses of pefsitinib, and 100 milligrams and 150 milligrams. SIs and herpes zoster related disease were higher in the pefsitinib groups compared to placebo, but there was no dose dependency observed in the instance of malignancy. It's a relatively small study to be building great confidence in that area. Well, our conclusions here, well, in Japan, patients with an inadequate response to methotrexate, rheumatoid arthritis, it would seem that pefsitinib has superiority over placebo in reducing symptoms and suppressing articular destruction at both doses tested. Moreover, the safety and tolerability profile seemed quite acceptable. There were no new safety signals identified, although, as I say, it's still really early days. We'd like to see more data here. Well, I hope that was of interest to you. All the content I've discussed this month is available in a more detailed slide format in the publications section at cytokinesignaling.com. And please have a look at these at your convenience. I hope you'll find it useful. It's certainly a resource I still go back to on a very regular basis. And please don't forget to subscribe to our podcast on our website, SoundCloud, or YouTube, and let us know what you think by leaving a review. So thanks very much indeed for listening. I hope you found this useful, and the best of luck in your clinical practice.